Started, I want to say good evening to everybody. Thank you for joining us to learn about oral health and older adults living in community settings. My name is Marla Morse, and I'm the Executive Director of Oral Health Ohio, which is an initiative of the Health Path Foundation, which is located in Cincinnati. Joining me today is Abby Haynes, who is the Grant Manager for Health Path and provides administrative support to Oral Health Ohio. For those of you who are not familiar with Oral Health Ohio, we are a coalition of partners who work to influence policy and systems to improve oral and overall health of Ohioans across the lifespan. Our work impacts Ohioans who face the greatest oral health disparities, which includes older adults. We encourage you to go to our website to become a member of Oral Health Ohio and to learn about our work. I want to acknowledge the Delta Dental Foundation for making this webinar possible. Social work education often overlooks oral health, which is a critical gap. We are grateful to Delta Dental for recognizing the vital role social workers can play in improving the oral health of older adults. Before we move on to this evening's agenda, I want to encourage you to put your name and organization into the chat box. And we would also like to know what oral health issues you see most frequently in your older adult clients. This could be anything from social determinants of health to, unmet dental needs. The agenda for this evening includes housekeeping items. Following presentations by Dr. Mahalaha and Dr. Hemmings, I will moderate a few questions. We're going to open up for questions to the audience, and we're going to also share resources. We encourage you to put any questions you have for the presenters into the chat box. And you will also be receiving a link to the slides from today's webinar. The recording and slides will also be posted on Oral Health Ohio's website. Continuing education credits are provided for this webinar. You should have received instructions for claiming CE or participant credit. If you did not receive email instructions, most likely your email was returned as undeliverable. We had this problem with last week's webinar as well. If you did not receive email instructions, please email me directly to let me know. And also please include your phone number so that I can connect with you and arrange the best way to get you the CE instructions. And my contact information is throughout the slides. There are no financial relationships to disclose for this presentation. The learning objectives for today's webinar include explain the unique oral health challenges faced by older adults, identify the connection between oral health and overall health, and identify at least 2 opportunities for social workers to integrate oral health into community settings. It is now my pleasure to introduce you to our presenters. Rosemary Hemmings has a master's in social work and a PhD in public health. She has developed and teaches an innovative interprofessional curriculum related to social determinants of health, health equity, and social justice within the School of Dentistry at Oregon Health and Sciences University. Dr. Hemmings has presented her research nationally and internationally in the area of social determinants of health and social work curriculum within dental education. Suparna Mahalaha is a public health dentist who focuses on oral health care for older adults in residential, skilled, and community settings. She's also an assistant professor at Case Western Reserve University School of Dental Medicine in the Department of Community Dentistry. And Dr. Mahalaha, I will now turn things over to you.
Thank you. Good evening, everyone. Thank you so much for spending a few hours with us this evening. Special thanks to the Delta Dental Foundation, Oral Health Ohio. Big shout out to Marla and Abby for putting this all together and being so supportive of this topic and this work. So thanks to you all. Next slide, please. So I am coming to you from sunny Cleveland, Ohio. I have been in the public health dentistry world for the last 23 years now. My career has taken me to work in all kinds of unconventional places, elementary schools, nursing homes, homeless shelters, adult day centers, community clinics. I spent many years at a local federally qualified health center. I was the chief dental officer there. Currently, I am an assistant professor at Case Western Reserve University School of Dental Medicine, and I'm in the Department of Community Dentistry with a special focus on geriatrics, and that's what I teach at the school. I'm also a nursing home dentist with 360 Care. Next slide, please. Okay, so I want everyone to close your eyes. Think about the lower third of your face right here, okay? And think about the last time you laughed out loud. Think about the last meal you really enjoyed. Think about the last time you had a great conversation with someone. Think about the last time you smiled to convey kindness and friendliness. So you can do all of these things without optimal oral health, but it does make it easier if you have it. Next slide. So when we talk about oral health, we're not just talking about the absence of disease. I think about oral wellness. And so what that means is healthy teeth, healthy gums, a healthy, clean tongue, the ability to smile with confidence, to speak, to chew, and to enjoy a variety of foods. Oral wellness is also being free of pain in the mouth and face, free of oral and throat cancer, gum disease, tooth decay, and tooth loss. Next slide. So oral wellness affects obtaining a job. It contributes to your confidence and your enjoyment. Oral pain is linked to difficulty chewing and inadequate nutrition, poor school performance in children, work loss in adults, to care for themselves and their children and their family members. Next. So the Surgeon Dental's report from 2020, has said that dental care is the most common unmet health need. Oral disease can negatively affect systemic health, and the disparities in oral health and access to care exist for all ages. Most oral disease is preventable or at least controllable. And that's the hardest thing as a public health dentist. When I see people who have just had years of neglect because they could not access care and then are now faced with very expensive kind of pathology to fix, if it was prevented, we would have never had to do most of the procedures we do in dentistry. So that is sort of a frustration point for me because so much of oral disease is preventable. The report also talks about interdisciplinary care is necessary to achieve, optimal oral health and overall health. Next slide. I think about this a lot, access to care. And this particular information struck me when I found it, that 111 million people visit primary care annually, but don't see the dentist. And 27 million people visit a dentist annually, but not a primary care provider. So we're definitely missing a lot in between. So that, forces us to think about, if as a dentist, are my medical colleagues talking about oral health? Are they referring to dental? Are they talking about systemic health and oral health? And as a dentist, are my colleagues talking about, hey, did you see your doctor? When's the last time you had blood work? How are you feeling? Checking for blood pressure. Really having that interdisciplinary conversation between the different disciplines. And I think if we did more of that, we wouldn't have such a varied amount of people not seeing the other specialties. Next slide. So poor oral health raises the healthcare costs, affects the person's quality of life, results in unnecessary pain, suffering, elevated risk of malnutrition, aspiration pneumonia, respiratory disease, diabetes, and cardiovascular diseases, contributes to bad breath and changes in the dental and oral facial aesthetics. Poor oral health can alter speech, can affect self-image and self-esteem, and that comes with serious psychological and social consequences. Next slide. So if you remember one thing from today's slide, or from today's presentation, is that the mouth is very much connected to the body. It's not separate, even though the insurance industry would like us to believe that. Older adults are more susceptible to systemic conditions, including oral diseases that directly or indirectly lead to malnutrition, altered communication, increased susceptibility to infectious diseases, and also diminished quality of life. Next slide. All of this seems very obvious, but this is something that, as a dentist who works in nursing homes and also with older adults in the community, I see how oral health and nutrition are very much linked. With painful teeth and gums, it's hard to eat solid foods, it's difficult to chew. Pureed foods can be high in carbs and sugar, and that cycle of decay starts. With no teeth or ill-fitting dentures, a balanced diet can be difficult. And you're not and a lot of people are not satisfied when they're eating if they can't chew and enjoy the foods they used to enjoy. And this can lead to isolation and weight loss. And then perhaps then one might compensate by eating soft processed foods, donuts, pastries, desserts, and other kinds of foods that can then lead to weight gain. Not eating enough fiber due to an inability to chew effectively can lead to constipation. Next slide. So periodontitis is a fancy term that we use for gum disease and how this is linked to diabetes. Periodontitis is an infection of the gums that, if left untreated, causes redness, bleeding, pain, odor, tooth mobility, and eventual tooth loss. To my hygienists on the call tonight, I know you know this slide very well, and you think about this a lot in your practice, that, if a person has diabetes, their mouths can be more susceptible to periodontitis. And because diabetes slows the healing process down, periodontitis is then harder to treat. So in a perfect world, a diabetic person should have access to optimal oral health and oral hygiene checks to prevent further exacerbation of disease. Next slide. So Alzheimer's disease is a devastating neurodegenerative disease that affects 1 in 10 adults over the age of 65. And there's 2 major types, familial and sporadic, sporadic being the one of the majority. Dr. Keiko Watanabe is a professor of periodontics and researcher at the UC College of Dentistry. And this is very exciting in our world. Her study is the first ever to show that exposure to periodontal bacteria can initiate the formation of senile plaques that are found in Alzheimer's patients. So that's huge. That suggests that chronic oral bacterial infection or the presence of bacteria product in the brain may influence the development of these senile plaques. And hence, chronic bacterial infection may be a risk factor for this type of Alzheimer's disease. Next slide. So I had this slide in my last week's presentation for oral health care in nursing home facilities, but I wanted to include it in today's as well to sort of talk about aspiration pneumonia. Aspiration pneumonia occurs when oral and gastric contents are aspirated into the lungs, which lead to infection. This often results from impaired swallowing or protective airway reflexes. The common risk factors associated with this kind of pneumonia include advanced age, dysphagia, altered mental status, neurological disorders, and conditions that affect the gag reflex or esophageal motility. So this kind of nursing home acquired pneumonia is currently the second most common type of infection among patients in long-term care facilities in the country. This is also responsible for a majority of the emergency department transfers. Pneumonia represents a 13 to 48% of all infection in nursing home settings. So I guess the point of this is, a lot of this can be prevented. Residents with poor oral health can aspirate this plaque into their lungs and associated bacteria. And, this can be prevented with daily oral hygiene. Next slide. There are many conditions that are associated with aging. I'm going to just focus on one tonight, but these are some of the others. Dry mouth, periodontitis, cancer, candidiasis, which is fungal infections, caries, which is cavities, burning mouth disorder, and traumatic ulcers. Next slide. So I chose to focus on this one tonight because I find this is oftentimes one of the most devastating in terms of what happens when your mouth stays dry and is dry. So we also call this xerostomia. So the picture that you're looking at is a picture of very dry mouth. You can look at that tongue and see there's almost no saliva there. And this is very uncomfortable and very painful. And it impacts the way you talk, the way you taste your food, the way the tissues in your mouth, become, you have little micro abrasions because it's so dry. You can hear dry mouth as well when people are talking and they have dry mouth. There's a certain sound it makes too. And we don't have saliva in your mouth. This is a protective factor against decay. So, if you don't have saliva in your mouth, you're not washing away any bacteria and carbohydrates that are just sitting on the teeth. When your mouth is dry, it just sticks to the tooth surface. Then this process just goes rampant in people who have, very severe forms of xerostomia. Sorry, many older persons do complain of dry mouth and have diminished salivary output. The 3 main causes of dry mouth are dehydration, polypharmacy, and depression. Other causes are for this decreased salivary flow or cigarette smoking, alcohol, caffeine consumption. That's why that question about, do you smoke is so important for every age group. And then other systemic conditions also can contribute to dry mouth. Next slide. We think about limited access to care, and as social workers and, other people in the oral health field, I'm sure you think about this too. I know I certainly do. Only 46% of elders visit the dentist. 70% lack dental insurance. Medicare does not cover preventive and outpatient dental treatment, which is a travesty in my opinion. Medicaid dental coverage varies by state, but is limited and often does not cover routine preventive services. But here in Ohio, yay Ohio, we have a pretty nice comprehensive Medicaid dental coverage, and with the recent increase in reimbursement fees, this is really actually a good time for our profession to be able to hopefully get more Medicaid providers to be able to provide more services because the fees have gone up. So, and on top of that, it's not just extractions and cleanings that are covered by our Ohio Medicaid. There's a full range of comprehensive services that are provided. Poverty, limited mobility and transportation, these all affect access to care, physical and mental impairments, impairments of vision and hearing. There's limited evidence-based care guidelines for this age group sometimes too. Oftentimes I talk to some of my older adults in the community, and they don't go to the dentist because their dentist's office no longer is equipped to handle, either their wheelchair or, the bathroom. I've heard this before. The restroom is too far away from the treatment rooms. So we have to start thinking about how our dental offices are equipped for older adult needs. And there are a few specialized geriatric dentists. So geriatric dentistry is not a official specialty in dentistry, but it's definitely a niche that some of us are finding our way into because there's a really great need. Next slide. So I want to just go over some quick dental terminology. The top row of teeth that you see there are filled with silver amalgam fillings. The bottom row are white composite fillings. Next slide. These are crowns and bridges. The picture on the left is a crown. It's where, one tooth is shaved down. Usually if it's fractured or there's decay, it can be removed. And then this crown or cap is cemented on over, and this is fixed. This doesn't move. And then on the right, you have bridges, a bridge. So a bridge is to restore an area between two teeth that has a space there. You can prepare teeth on either sides and then, have a fake tooth that's in the middle, and this all gets cemented. This is called a fixed bridge. Next slide. I want to put this picture in here as well. So this is an edentulous mouth, and an edentulous mouth is a mouth with no teeth at all. There's two pictures here because I wanted to see if you could see the differences between the height of the bone. So you're looking at the upper jaw and the lower jaw in both pictures. And in the picture on the left, you can see that lower jaw, it's sort of flatter and it's smaller. And in the picture on the right, it's a little bit rolled better. There's a little bit more of a ridge there. So as a dentist, when I look at this, I'm thinking, okay, the denture we make for this on the left is probably going to be loose. Nice candidate for implants to be placed, and maybe a denture fabricated to clip on and off of those implants. But I often get questions about, oh my gosh, my denture is loose, or my older adult that I take care of, the denture is so loose, it wasn't made right. It might not have been made right. I'm not saying it wasn't, but oftentimes, as people age, sometimes these jaw bones atrophy and they become smaller. So when the bone is not enough, that denture has nothing to sit on, and you have a denture that's moving around and very dependent on denture creams and denture powders and things like that. Next slide. So this is a complete denture, upper and lower. Next slide. Oh, and then if you go back real quick, please. Okay, so when people wear dentures, it's very, very important that these come out every night. People should not be sleeping in their dentures ever. Because if you think about it, I always tell my patients this, I'm like, would you ever wear your shoes to bed? You don't wear your shoes to bed because your feet need to breathe and your shoes are dirty. Same concept in the mouth. The gums in the mouth need to cleanse themselves at night. They need to breathe. You can't have a piece of plastic up on top of those those tissues of the mouth, because it then creates like a warm and fuzzy environment where fungus love to grow. So then you get into candidiasis and yeast infections in the mouth. And again, super preventable. I see it all the time in nursing homes. I see it a lot in my older adults who live in the community as well, because many years ago, their dentist told them never take your dentures out. So they just don't take their dentures out. So if you are in a situation where you could educate somebody and say, those dentures have to come out every night, they need to be brushed, they need to be soaked, and then pop them back in, in the morning. Next slide. This is a partial denture. This is when a person has, some remaining teeth, and which is always great to have a few anchor teeth to be able to clip this partial denture right onto those teeth. It's a little bit more stable then too. Next slide. These are implants. Lots of people ask about this a lot. Unfortunately, most insurances do not cover it. It's an out-of-pocket expense. It is expensive, but it is really one of the best options, if you do have spaces in your mouth. Next slide. So this is like, I thought about when I was writing this slide, how can the social worker help our field, help the cause for oral health? And I think it'd be really great if you made oral health a priority for yourself first, because then if you understand why it's so important for you, you can help your clients and your residents and people in the community to also think about it that way. You make referrals as needed. You know your local resources. Community health clinics, federally qualified health centers, schools of dentistry and dental hygiene, private dentists in your counties and your areas. Also find out who take Medicaid insurances. AARP resources are there as well. I know at Case Western, we get calls all the time from people in the community who want us to come in and do outreach and education, which we're happy to do as a school of dentistry. So I encourage you to call those schools, call the dental hygiene schools, if that's even something they can offer, to come out and educate and provide some guidance on oral health. I think that's something you can also offer, your communities as well. You can work with community health workers and community dental health coordinators. This is a new group of people working, to sort of help people connect to care, teach about oral health. These are great resourceful people as well to help navigate people through the oral health system. I think a great question you can ask your clients and community members, do you have pain in your mouth? When was the last time you saw a dentist? Even residents without teeth need an oral screening yearly. I get that question all the time. Well, I don't have any teeth, so I don't need to see the dentist. No, you absolutely have to, because we still need to do that oral cancer screening at least once a year. We check the tongue, the floor of the mouth, the cheeks, the lips, even the gums, the jawbones. We need to look at all those structures and make sure everything looks good. I also always remind people, don't forget about your tongue. If you don't have teeth, you still have to brush that tongue, because the tongue can, harbor a lot of bacteria and odor as well. So the goal is holistic care. Care coordination and interdisciplinary collaboration are always welcome. Next slide, please. These are my references. And I think we're going to take questions at the end. I'm sorry I kind of blew through that a little bit quick, but I was hoping to get through everything. Thank you so much.
My turn. Hi, everyone. Dr. Hemmons. Marla did a great job in terms of my introduction. I'm coming from Portland, Oregon, the beautiful Northwest. And, it's a lot of people ask the question, what is a social worker doing in the School of Dentistry? I have a social work degree, a master's in social work, PhD in public health. And I just think those are the perfect combination to be in dentistry. And there's a personal reason as well. I didn't see a dentist until I was 13. And when I did go to the dentist, because I was in so much pain that I couldn't go to school. And when I did show up at the dental office, the dentist just totally, completely ripped my mother apart and myself. Told her that she was a neglectful parent, told me that I wasn't taking care of my teeth. And that has stuck with me. I go to the dentist every 6 months now, but I could tell you 2 weeks before every appointment, I'm stressed out about it. And when I go there, I'm stressed, I'm anxious. And the minute a dentist says to me, oh, I think I see something, I'm ready to never return. So one of the things I try to teach dental students is that every mouth has a story, and they should focus on trying to get the story behind what they're seeing rather than being judgmental, inflicting bias in the way in which they proceed to care for their patients. Next slide, please. So as we think about social work and what we do, Dr. Mahala mentioned holistic care. That is fundamental to social work practice, where we focus on the mind, body, and spirit. We are very much concerned about those who are most vulnerable. When we think about older adults, they certainly fit into that category. We care about the suffering of people, of human beings, and that would include, the suffering that comes about when your oral health is not where it should be, whether it's not being able to smile, not being able to go on a job interview, isolation as a result of oral health, not to mention the health impact of having poor oral health. And then finally, of course, social change. Social change is a fundamental basic principle of social work practice. And it's something that we should always apply in the work that we do. Social work has changed significantly since I went to school in the 80s. A lot more social workers are being more clinical in practice, and sometimes have forgotten that advocacy is something that we should all be doing. And there's always a place for us to advocate for communities and advocates for our patients. Next slide, please. So, if we think about oral health and overall health care, if you listen to the conversations that occur around policies, around health, even health insurance, you will notice that often oral health is not mentioned. It's not highlighted. Even the way in which we have our insurance system that's set up, oral health is separate from physical health. Most jobs that offer insurance, you have the option of selecting whether or not you want oral health, dental care, or vision. And then there's the physical health insurance. Younger populations may opt not to take dental insurance or vision insurance. And that's how we see what ends up happening as we get older. We haven't really had access to oral health, or even the opportunity to learn about the importance of oral health, as Dr. Mahala just talked about, how our overall health can be impacted by poor oral health. And we think about us, even as social workers, right? When we were going to school, we didn't learn about oral health. When we think about our assessments, that was not part of what we learned that we needed to find out from our patients. When was the last time they saw the dentist? Are they having any pain in their mouth? That wasn't something that was taught. So when we see what we see today in terms of older adults, it's a combination of all the different things that have happened within society over the lifespan of individuals. Next slide, please. So I think Dr. Mahala covered this, but I just want to focus on the impact of mental health, isolation, depression, anxiety, eating disorders, and substance use disorders. When we think about how oral health plays a role in our mental health, if you're in consistent pain, it's very difficult for you to actually have a mood that is healthy, right? Isolation. If you feel that your mouth doesn't look right, you have broken teeth, they're stained, they're rotted, decay is the proper word for that, Dr. McCullough. It's less likely that you're going to want to be out and about and, meeting and talking with people. If you're not able to express yourself verbally or even facially, right, non-verbally, it impacts your ability to be able to socialize with other people. So that increases the likelihood for depression. And also think about anxiety. What I described to you about myself, my own personal experience, I have what's called dental anxiety, right? That is something that as social workers, when we're doing our assessments, we need to get a history of our clients' history around oral health care. Does this person have anxiety in general? Do they have dental anxiety? Because then we need to help them to be able to communicate that with their dental providers. Eating disorders. One of the things that our dental students learn is how they can identify someone who has an eating disorder. And a lot of times what happens if someone has an eating disorder, when they vomit, you will see acid erosions on their teeth, right? And we teach them harm reduction. So yes, we want to treat the eating disorder, but how can we reduce the risk of the behavior from eating disorders? And one of the things that we will teach them is to rinse their mouth, right? Also, the dental students will prescribe, Dr. Mahal, you didn't mention this, will prescribe fluoride treatments, right, for patients as well. Substance use disorder is another negative impact of having poor oral health. One thing I didn't mention here is DV, domestic violence cases, right? We see this sometimes in the clinic where we'll have clients who have had a history of being in domestic violence relationships. And we find that oftentimes the mouth, because the face, right, is usually the target of these violent episodes. So you'll find that a lot of times we have DV clients who will come in and their oral health is poor, they have broken teeth, and that's because they were survivors of domestic violence. Next slide, please. So some of the unique challenges faced by older adults is we're living longer, right? And as we live longer, it's even more important for us to be able to retain our teeth. Teeth retention helps us to be able to chew, to eat, to smile. And when we lose our teeth, it creates problems for us both physically and psychologically. Limited access to dental care and insurance as you get older. As you know, Medicare in of itself does not cover dental care. If you happen to have a Medicare Advantage plan, yes, you may have access to dental care, but how many people are even aware of that, right? And to get private dental insurance can be very expensive and costly. Medication side effects, Dr. Mahala mentioned this. When you have a client who's on psychotropic medications, that can also impact their oral health, dry mouth, the taste bud changes because of the medication. And sometimes not just psych meds, but just any medication in general can actually alter taste buds. Mental distress, self-isolation due to embarrassment, sleep disturbances, and poor ability to concentrate. Pain. If you're in pain, it's very difficult to concentrate. I don't know how many of you have had a toothache before, but as I said, I have had, and I know it's horrible. It impacts your entire body. An impact on daily quality of life, chewing, swallowing, altered taste buds, and smiling. Next slides, please. So what are some of the opportunities for us as social workers to incorporate oral health in community settings? One of the first things I think we should do is to include oral history in our assessments. Just the same way we would ask about history of domestic violence, history of, their basic overall health and well-being, we should include oral health in history. So we should be asking our clients, when was the last time you saw a dentist? Did you see a dentist regularly throughout your lifetime? Do you have access to dental insurance? What was your experiences like when you did see a dentist? When we're assessing for traumatic experiences as part of our assessments, that should also include oral health trauma, right? Whether or not they have dental insurance, and provide education around access to dental care within your community. And I know after this, we're going to provide you with some additional information around what might be available in Ohio. And look for risk factors: heart disease, diabetes, eating disorders, substance use disorder, medication. Is this someone who's able to take care of themselves? Are they dependent on other people to provide care for them, take care of their physical care, dressing, bathing. And if so, that's a high risk factor in terms of oral health. Does their caregiver know how to take care of their oral health? Someone who has cognitive function decline, isolation, mood disturbances, socioeconomic status is a factor. Dental insurance, whether or not there's elder abuse or neglect history, those are all high risk factors for us to look at what the oral health of this person is. And advocacy. One of the things that, I notice as I just go through life and work within the healthcare system is there is a lack of understanding around the importance of oral health. And I think as social workers, we are the ones who we were the ones actually who created care coordination of care, case management, right? It was taken away from us by nursing discipline, but that's something that came out of social work practice, right? We are the ones that usually are able to bring all the disciplines together, right? To really look at our clients holistically. And I think it falls on us to actually be that person in that space, in that multidisciplinary space, to actually highlight the importance of bringing in oral health into the discussion. Research dental resources and identify barriers to access to care. Are there social determinants of health issues that may be a barrier to your client being able to access dental treatment, such as transportation? Is there financial issues, lack of or inadequate insurance? What is their health literacy? And this goes for the caregivers as well. And as I said before, dental trauma, okay? Educate caregivers, importance of good oral health, the risk factors, options of paying for dental care. One of the things to consider is there may be care credit options. Now, care credit is limited because in order to apply for care credit, one, you have to have good credit, right? And then you have to be able to make those monthly payments. Dental insurance options, check out low-cost dental services within your community. The other thing is that we do sometimes in the dental school is we will counsel our patients around working with the dental student, the dental provider around, okay, so this is my treatment plan. My overall treatment plan is let's say $1,000, right? And we try to counsel our patients to help them figure out and communicate with that dental provider around how they would be able to pay that $1,000, right? So which of my treatment of this $1,000, which is the most important? What should I do first? Because maybe I only have $300 right now, right? So what treatment can I have for that $300 that I can afford? And what time frame will it take me to be able to come up with the balance? So being able to have that communication with the dental providers is very important. And as social workers, we play a role in teaching our patients, teaching our clients, teaching the family members and caregivers how to advocate for themselves with their dental providers. And just always ask a question. Do you have any pain in your mouth, right? If you don't ask, we don't know. And when we don't ask, then we don't really get to find out what's going on. And also we don't get to find out whether or not our older adults actually need oral health care. So we should always ask the question. It should become a routine part of any intake, any interactions we're having with our clients. Next slide. Cute at 6 years old. I used to think that losing your teeth was normal as you got older, that eventually as you get older, you lose all your teeth, right? But that's not so. If we have good oral health care and we have access to oral health, we don't have to lose our teeth. It's not cute when you're 70 years old and you're missing your teeth and you can't get to enjoy the foods that you like. Next slide, please. These are references. Thank you. You're muted, Marla.
Thank you. Abby, let's come off the slides for a minute. And so that, oh, okay, there's a question already. Well, go ahead, Jane, Colette has a question. And then after Jane, I'm gonna, ask the, presenters a couple questions and then we'll open it up to the audience. But please also raise your hand, come off mute, put it in the chat, whatever you're comfortable with. Jane.
Okay. I thank you both for spending your evening helping us. I want to ask Dr. Hemmings if she could help me understand that process of advocacy or care coordination for the social worker. You know, for example, if there's a client that has unmet needs or hasn't had a dentist for lots of years, you know, how specifically does that social worker help to get through the systems like the insurance and, you know, so I'm just wondering what that looks like hands-on. Thank you.
Thank you for that question. And, you know, it's a multi-step approach, right? So if you have identified a client who has not seen a dentist or needs to see a dentist, right? You first would have to find out whether or not they have insurance, right? And one of the things that we do is we always assess all of our clients that are referred to us in the dental school. We assess to see whether or not they qualify for Medicaid, right? That's the first thing that we do. The second thing that we do is we have a list of what we call low-cost dental services in the community, in the state, really, that we will give to our patients, right? So we're assessing to see if they're qualified for Medicaid. If they do, we work with them to apply for Medicaid. At the same time, we're also giving them that low-cost dental service resource list. In addition to that, we're also working with this is someone for you who probably hasn't seen a dentist, so you have to get them connected. But you have to get them connected to a dental provider who, one, is accepting patients and accept if they have insurance, if it's Medicaid, that's accepted Medicaid, right? If not, I always recommend that you do research to try to find out, is there a dental van available? Are there low-cost dental clinics? FHQ facilities might be an option as well. So it's really being proactive, I think, in making sure that you identify what resources are available in your area. So you have that on hand as you do your assessment with the client to assess whether or not they have insurance. Does it cover dentistry? Are they eligible for any type of insurance? Can they afford to pay for private insurance? Because we don't always want to assume that someone can't afford to pay for it, right? And then connecting them to a dental provider in their area. And then it's, if possible, need to get a release of information to communicate with that dental provider about anything that you have discovered in your assessment of that client that might be helpful to them. Hey, this is someone who has a history of domestic violence. This is someone who has an eating disorder. This is someone who has depression. This is someone who has a joint replacement. Any information that you might have that might be helpful to that dental provider in providing care. And that's where the care coordination comes in, as long as you have an ROI. Okay, I hope that's helpful.
Thank you, Dr. Hemmings. Abby, I'm going to have you monitor the chat as I ask our presenters some questions. You know, just to follow up, Dr. Hemmings, on what you're getting at is that, there is access to care issues. First of all, we have challenges within the dental workforce, right? We have the dental team, we have workforce shortages in all the dental team, right? The dentist, the hygienist, the dental assistant. And then we have, issues with people who do not, as you said, have a provider in their county that would take the insurance that a person may have. And I know the social workers are really tenacious at connecting people to resources. And then we have 7 managed care plans in Ohio, and that we can get folks, it is the responsibility of the managed care plan to get somebody who lives in a county that doesn't have access to service to a county. So I'm just wondering, in either one of you, Dr. Mahalaha or Dr. Hemmings, if you can add anything to this issue of access to care, and if somebody is in pain or has unmet dental need, is there anything that they can do when we have such big access problems?
Do you want it? I'll let you take that.
That's a great question. That's hard, when there are so many access to care issues. I think if somebody does not have insurance, then working with social workers, other people in the community that can help them connect to some sort of insurance. And if somebody does have insurance, just also understanding how to navigate their insurance, because if somebody does have dental insurance, you can contact that insurance company and find out lists of providers that are close by to you, if that's an option. Now, if you don't have, I see a question here. Yes, the problems are definitely magnified if you don't speak English. Absolutely. And I think local FQHCs usually have translators and interpreters on board, or at least access to. I know the one I used to work for in Cleveland, I can't remember the name of it now, but there was an iPad and a live person would come on in any language. There's like 60 languages you could choose from. So that was a great way. I remember I treated a man who only spoke Cambodian, and there was no translator on site, but we were able to connect with him by this virtual assistant. I think getting ahead of pain is possible, more preventative visits, if we could do that. But if somebody already is in pain and they don't have places to go, I think a good start might be those FQHCs and community health clinics in the areas, or schools of dentistry or schools of hygiene.
Thank you.
Yeah.
Oh, go ahead, Dr. Hemmings.
And in addition to that, I mean, once again, it's the whole body, the whole person. I think another resource, which might be a last resort, shouldn't be, but does this person have a medical provider? If they're in pain and they don't have access for whatever reason to a dentist, maybe, speaking with their PCP and say, hey, I know you're not a dentist, but this person is having pain. What would you suggest in terms of, pain management, right? Because technically, social workers, we're not doctors, right? So we're not supposed to be telling patients what to take. I may know what they should take because I work in the dental school, and I know they always tell them every 6 hours they would take this, and every 4 hours they would take this, Advil, Tylenol, but that would not be something you would say. But certainly if someone is in pain, you want to get them out of pain, right? And I would say the PCP, primary care doctor, if they have one, that they should see them and, recommend something. It's probably over the counter.
Thank you. Marla, there is a follow-up question from Jane. I'm not sure if you all saw that one. It says, is there one particular social determinant that is most common as a barrier to accessing oral health?
I could answer you that question. Finances.
I was going to say cost as well. Yep.
Yeah, finances, not having health insurance. And even when they do have health insurance, insurance may not cover certain treatments that they need, and they can't afford to pay for it.
Yeah.
Transportation is another issue that we see in Oregon, because we have a lot of rural communities, right? And access to transportation to get in to see a dental provider because they may not have a dentist or a dental hygienist in their area, so they have to travel sometimes 2 hours to find one. So transportation is another piece too.
Thank you. I do have a couple more questions I want to ask. Dr. Hemmings, I'll ask you first. You mentioned the role of social workers as advocates, and one way that social workers can advocate for their clients is to look for opportunities for oral health integration into behavioral health, mental health, and physical health. And I think one thing that we think about is we can't always just rely on the dental provider. We know that there's certain things that particularly around children, which of course not the population we're talking about today around prevention. Can you think of any opportunities that social workers can take in the community-based settings to integrate oral health with these other kinds of providers, even if it's oral health promotion?
I think the first thing is to actually mention it. Mention it in the spaces that you're in. Anytime you're in an interdisciplinary meeting, bring it up. Say the words, oral health, right? That's advocacy. And also we need to get back to the grassroots where we're actually beginning to look upstream at policies, right? And to advocate for changes in the way oral health is treated on a policy level. I mean, yes, it's great to advocate within our own organizations and, with our own dental providers, but I think we need to think further about upstream, which is the policies that are made on the state level, right? About what insurance covers and what it doesn't cover. I think that's the role that social workers used to play, and we need to get back to that.
Thank you, especially a dental benefit in Medicare.
Right.
Yeah.
Partner
Oral
with
Health Ohio is working on that, but
partner with organizations like
nationally, yeah.
Marla's, right? Yeah.
So, Dr. Mahalaha, I want to ask you just a question. You mentioned, how important saliva is in dry mouth, and we know so many of the medications that older adults are taking do cause dry mouth. In addition to the mental health, the psychotropics, all the chronic diseases that folks are taking. One thing I've noticed is that when people have dry mouth, they eat candy to keep their mouth moist, and that's probably not helpful. What are there things that you could tell social workers about that might be helpful for folks, or if there's anything over the counter? Because I think this is an issue for people, dry mouth across the lifespan, but especially older adults.
So there's a product over the counter that you can get in the dental aisles called Biotene. They have sprays, they have rinses, they have gels. They even have toothpaste. I think you would start there. That's one of the major ones. And even some of the other brands now do carry dry mouth formulations of pastes and sprays and things like that. And everything's right in the dental aisle. If you go on Amazon, you can order, or even directly, there's All Day 5000 is a really good one right now. That's for dry mouth toothpaste and also rinses. If you just look that up, All Day 5000. I think you get on Amazon.com, and you can also get it directly from the manufacturer. Keep a water bottle all the time, with you if you have a dry mouth. I think one thing to note is, I had a patient who just had lemonade with her all day long because she had such a dry mouth. But, you've got an acidic beverage and a ton of sugar and no saliva, and that is the perfect storm to get rampant decay. So like almost every one of her teeth had cavity in it because she just kept chugging lemonade all day and didn't know, she's want to keep her mouth moist, which is understandable. But I would stick with water, fruit flavored water. Like I minted my water today, cucumber water, blueberry water, anything that has a little bit of flavor, and just regular water is best to keep on hand. So the sprays, water, I know a lot of people do lozenges as well. If you can find the sugar-free kind, that's better. If you can find I think there are some lozenges that have xylitol in them. I know recently there was I don't know if you heard this, but there's been an article that's come out saying that xylitol in some concentrations can lead to cardiovascular disease and other issues. So there's a lot of research still needs to be done about that, but I think in the concentrations that, you find in sugar-free lollipops and lozenges, I think it's fine for now. So I would start there.
Thank you.
Also,
you know- Oh,
sorry,
go ahead, Dr. Hemmings,
you know
sorry.
who else is really helpful? Dr. Mahala mentioned about sugar. You know who's really helpful on our team? The dietitian.
Mhm.
Yes, collaborating, coordinating with the dietitian can help to minimize risk with oral cavities.
Thank you. Thank you for that. Abby, if you could just really quick, we only have a couple minutes left, and I wanted to share some information very quickly. We are going to share the slides. I will get those out to you tomorrow. But I wanted to tell you about one particular resource that, could you go to the next slide? Let's see. Well, first of all, we provided, direct links. You'll be able to press on these, some from Delta Dental. We provided a list of all of the safety net clinics, how to get dental care for HIV/AIDS, we just have lots of dental safety net clinic resources here for you. But I want to talk to you. I also want to mention, I don't know if a lot of you know about the Dental Options Program, which helps adults and older adults to get dental care by linking them with volunteer dentists. Now, there's a waiting list, but it's still an option, and you can look at that. Really quickly, in the 2 minutes we have left, I want to go to the Motivated Home program. If Abby, could you go to the next slide? So Motivated Home is a free oral health education program for families of older adults living in their home. And this is a program out of Maine, and family members will learn the connection between oral health and overall health, why older adults are at greater risk, the steps for adequate at-home oral care, and how to talk to the healthcare provider. If you go to the next slide, Abby, please. Families can select on these different topics, and there's all sorts of information there. Again, this is for people who are caring for people who live in the home, in community settings. And then if you go to the next slide really quick, what's wonderful about this resource out of Maine, and they've opened this up nationally, it's a new program, is that if you put your email in there, you will be notified about a live event where you can ask questions from a dental expert. And I think this is really helpful for families who live in communities. Particularly, it's not going to get them to a dentist if they're in a dental professional shortage area, but it's really rich information, and I think it's a great resource. And then in the slides, next slide, please, Abby. There's a video, and this is a caretaker. You don't have to play the video. We don't have time. But, she talks about what this program does and how beneficial it is. So this is a program out of Maine, and I highly recommend it to all social workers and other professionals outside of dentistry, within dentistry and outside of dentistry, rather, to, help with our caretakers who are caring for folks, older adults in their home. So at that, it is 7:30. I want to thank everybody for coming tonight. Thank you for your time. I'll send the slides out tomorrow. The recording will be on our website probably in a couple weeks. But if you have any problems with CEs, just email me directly, and I will get those worked out for you. Thank you, everybody. Have a safe 4th of July holiday.
Thank you all.